Good morning. I am Dr. Pedro José Curi-Curi, Professor, Cardiovascular Surgeon, and Postgraduate Unit Chief of the Direction of Planning, Teaching, and Research at the High Specialty Regional Hospital of Ixtapaluca, Mexico. I'm going to talk to you about a research in brain natriuretic peptide as a prognostic factor in COVID-19. Background is referred about coronavirus type 2 that has been implicated as the etiological agent of coronavirus disease 2019, COVID-19, which infectious clinical spectrum goes from an asymptomatic process to a severe respiratory failure that can lead to death. Brain natriuretic peptide, on the other hand, a hormone mainly produced at the heart ventricles due heart wall distension, promotes vasodilation, increased diuresis, and produces suppression of the renin, angiotensin, aldosterone system in order to decrease heart preload. BNP has been recognized as heart failure biomarker and has also been used as a prognostic factor in patients with sepsis and septic shock, regardless of their previous cardiovascular condition. Therefore, we aimed in this study to determine if BNP can be also used as a prognostic factor in patients with SARS-CoV-2 infection. We designed a retrospective, observational, analytical, and cross-sectional case control clinical study in order to recruit all patients admitted to the internal medicine service of a third-level hospital in a 1-month period during the 2020 pandemic. Inclusion criteria were patients over 18 years, diagnosis of COVID-19, confirmed by reverse transcriptase polymerase chain reaction. Exclusion criteria were previous diagnosis of chronic heart failure, chronic kidney disease, hyperthyroidism, chronic liver disease, malignancy, and history of subarachnoid hemorrhage last 3 months. Elimination criteria were chronic kidney disease during hospital stay, serum creatinine levels above 1.5 milligrams per deciliter, and blood glucose above 250 milligrams per deciliter. Patients recruited were divided into 2 groups. Control group, which included patients discharged at home because of clinical improvement, and problem group, which included patients died at hospital stay. Both groups, at the first 24 hours of admission, were submitted for collection of data, including clinical background records, comorbidities, medication intake, vital signs, anthropometric measurements, and laboratory studies that included hematic biometrics, blood chemistry, liver function tests, ultrasensitive C-reactive protein, procalcitonin, ferritin, and blood BNP levels. All these data were collected at an Excel spreadsheet and analyzed by a SPSS software. A sample of 100 patients was obtained out of a total of 204 clinical records studied. 50 patients were randomly assigned to each study group, problems, and controls. This table compares the sociodemographic variables, somatometry, and vital signs of the studied groups. We can see a difference between age. At the problem group, age was older than the control group. Male gender predomined in the problem group. Systolic blood pressure was higher than the control group in the problem group, and oxygen saturation was poorly compared with the control group. This table resumes the laboratory variable of the studied groups. We can see higher levels in the problem group compared with the control group in blood count of hemoglobin, leukocyte, neutrophils, uric blood nitrogen, DHL, and PCR. We developed a ROC curve for BNP values in the group of deceased patients and observed a cut point of 32 picograms per milliliter of BNP as the point of higher sensibility and higher sensitivity. In this grouped bar chart, we can see the comparison with the BNP values at the cutoff point established by the ROC curve. We can see that BNP values above 32 picograms per milliliter were higher in the problem group than in the control one. This contingency table of the frequency of BNP values at the cutoff point established by the ROC curve in both study groups showed a statistically significant difference in the problem group where BNP was above 32 picograms per milliliter in comparison with the control group, with an odds ratio of 13.5. And finally, this is a Fagan nomogram summarizing the characteristics of BNP as a prognostic study of in-hospital mortality in patients with COVID-19. We can see a prevalence of 50% and a positive likelihood ratio of 6, which means that positive post-test probability is 88%. As well, negative likelihood is 0.44, which means that negative post-test probability is 31%. Elevated morbidity and mortality due to COVID-19 lead to develop prognostic factors for identification of patients with the highest risk of death. These include advanced age, above 65 years, aging and cellular senescences of the immune system are factors that leave the elderly patient in a vulnerable state. It was observed that in the problem group, most of the patients were in the 5th decade of life, and although they were not older than 60 years, it is corroborated that age is a prognostic factor for outcomes. Another factor is male gender. Male sex hormones facilitate the entry of the virus into tissues, since they increase the activity of the ACE2 receptor and favor the expression of the transmembrane protease serine 2. Male gender predicts the higher mortality rate compared to female gender in the problem group at our study. Another recognized factors were chronic degenerative diseases such as diabetes, arterial hypertension, obesity, and cardiovascular diseases. Hypoxia itself is a consequence of alterations between ventilation perfusion caused by the presence of pulmonary edema and loss of alveolar elasticity, which produces alveolar collapse and therefore alterations in hematosis. Under hypoxic conditions, the juxtaglomerular cells of the kidney were stimulated by factor 1 alpha to favor the secretion of erythropoietin, which in the bone marrow favors the production of red blood cells, of which main component is hemoglobin. This explains why the patients in the problem group with considerably low oxygen saturation have significantly higher hemoglobin levels compared to the control group. Inflammation produced by SARS-CoV-2 myocardial damage is also mediated by the uncontrolled release of cytokines as an excessive immune response that leads to cardiac dysfunction. Myocardial damage is the consequence of leukocytes that are attacked by inflammatory signals to cardiac tissue, producing numerous reactive oxygen species at the site of injury and increased oxidative stress, which leads to cardiomyocyte deterioration associated with modification of contractile proteins and dysregulation of cellular redox states. This promotes apoptosis of cardiomyocytes and determine a state of reparative fibrosis. This inflammation in myocardial damage produces an elevated BNP blood levels. Therefore, BNP is a cardiac biomarker associated with mortality in patients with sepsis and septic shock. But there are few researchers related to the prognostic value of BNP as a biomarker in COVID-19, since the seric evaluation of N-terminal prohormone of brain natriuretic peptide above 88 picograms per milliliter has mostly been used as a prognostic biomarker for high rates of mechanical ventilation, intensive care unit admissions, and a twice probability risk of in-hospital mortality, regardless of a clinical background on a previous heart damage, with 100% of sensibility and 66% of sensitivity. Our work in the present study, BNP was studied as a mortality predictor biomarker and showed a relationship between elevated levels and in-hospital mortality in patients with COVID-19. With a 32 picogram per milliliter as a cutoff point, the elevation of BNP is thought to be multifactorial, but must be associated with the expression of the angiotensin converting enzyme receptor 2, AC2, in cardiac cells, which allows SARS-CoV-2 to infect and replicate within cardiomyocytes, leading to myocarditis as a direct cytopathic effect, which increased cardiac biomarkers. Therefore, we concluded that an admission BAP level above 32 picograms per milliliter is associated with a higher in-hospital mortality in patients with COVID-19 and can be considered as a prognostic factor for this disease. This study becomes important as no articles have been published that related B-type natriuretic peptide with in-hospital mortality in COVID-19 population. It suggests as well a new low-cost and useful prognostic factor for SARS-CoV-2 infection. And thank you very much for your attention.